It's a fantastic presentation, Jackie. So questions from the panel. I mean, certainly LA closure, there were some initial concerns with complications that perhaps delayed the initial adoption, but it certainly has changed in terms of safety profile. But some of the complications are actually can be quite unique, especially the retrieval issues. Questions from this panel for Jackie.
Yeah, hi Jackie, great talk. Quick question though, for someone looking at this and saying, I want to avoid an embolization. I know there's, obviously we want to do the pass criteria on table, but if you had a situation where you had a device with lower compression rates, say 8 to 10%, versus putting a larger device in which had higher compression rates but has a shoulder, which way do you fall normally to say, maybe I want this device to not move? Which way do you usually go? Do you like to overcompress or just try to get the device snug?
That is a good point. And I think, Sri, thank you for that question. And I think optimal sizing is so absolutely key to start with, right? Which is like baseline imaging with CT, for instance, will help you sort of gauge which is the better size to start with. And once you start with one single device, now removing it entirely and then replacing with a new device, obviously you have some risk associated as well. So there is that tendency of reluctance to change to a different device. So if you say have a first device in that might be slightly under compressed, 8 to 10%, is really relatively low in compression rate, but it meets all the other test criteria and is relatively stable, I might let it go. It just depending on what the challenges are in terms of getting the sheet back in position, et cetera, how much depth you have. So it's going to be quite individualized. I personally don't worry so much about over compression if it's not really more than over 30 or 35% compressed. I'm not too worried about it. And I would tell you that these complication rates of the Gen 2.5 will be dramatically different when you have access to the Flex device. I've been using Flex now for, gosh, with a pause with the pandemic, there's been a little pause there. But, we're coming up to about 20 cases with the Flex device since we started. And it's a remarkable device. I would say that the risk of pericardic effusion is going to be much lower. The risk of embolization, when you look at the Pinnacle Flex study, was 0%. I mean, in the clinical use, yes, we're going to see a few, but isolated cases. The fact that the iteration changes in the new generation with 2 rows of hooks and wider width actually does reduce the embolization risk. So I think that's going to be less of a concern when they move on to the new generation Flex device.
Jackie, great talk. Question about your opinion on the use of ICE with CT pre-planning. It's something I know Didi Wang has advocated for, getting a CT beforehand. It's subject to less of the sizing discrepancies that we might see with TEE and loading conditions. What are your thoughts on doing that and the pros and cons of adopting that approach?
Thanks for the question, Rahul. Great question. And I really think this is where, the next phase of LA closure procedures are heading towards. Is really, CT pre-imaging is really highly adopted now, and especially for ICE imaging. And in this COVID era, I would say we've entirely stopped doing TEE before the procedure, right? Because getting TEEs is so complex now with trying to make sure that, patients are COVID negative, et cetera. So we routinely only do CT pre. And I would say absolutely for ICE imaging guidance during the procedure, because the image acquired it's not going to be as good as the TE images in those instances. So you really do need some proper measurements in 3D fashion prior. So CT, I think, for ICE-guided procedures is mandatory. And that's what we're doing actually nowadays. We're trying to transition more to ICE guidance versus just TE guidance. And I think you're going to see many centers heading that way, especially in the pandemic era.
Jackie,
what go ahead, Paul.
Sorry, what proportion of cases are ICE guided versus TE?
Good question.
Sorry, could you hear me?
Yeah, you broke up a little bit there. So I think you were asking what proportion of the cases are ICE guided versus TE guided. We're definitely seeing in many European centers that a lot of centers are moving towards more so doing ICE guidance. Right now, we are probably doing 15 to 20%. We just did a day yesterday or 2 days ago with 4 TE guided, and another day in 2 weeks is going to be all ICE guided. And I would tell you that with ICE guidance, without TE guidance right now, we have to follow, post intubation. You need to wait that 10 minutes before the clinical staffs can go into the operating room, et cetera. So there's definite delays. And so ice guidance is going to just make the flow of the day so much easier. And I think if you have CT pre, ice guidance is a relatively straightforward procedure, but there are different ways of doing ice guidance as well, right? Some operators have not been putting the left atrium. I just think that those images obtained are not optimal if you're not placing the probe in the left atrium. And so that's my preference. And there are different techniques to do that. I know that Gagan, you've done a bunch of ice guided LA closures as well. So, maybe your comments as well would be appreciated.
Yeah, I thanks for that, Jackie. I think ice guided LA closures is something that we're going to see more and more of. The technology certainly needs to improve. The Siemens catheter, the 4D ice catheter, we've done a series of both MitraClips and Watchmans with just the 4D ice catheter, and it's a remarkable improvement from just the 2D catheter. You definitely, the multiplanar reconstruction allows you to kind of identify the left atrial appendage. You can do a planimeter of the ostium, and you can get a measurement. You can get depths. You can get, even the mitral valve. You can make assessments on the mitral valve as well. It certainly is a feature, but it has a long way to go. It will not supplant getting a CT ahead of time if that's the way you're going. It will not supplant the use of TE if you don't have some sort of imaging beforehand. You certainly will see more of it. Now, kind of control of the catheter in the left atrium, ability to manipulate it is very different. If you've not had your hands on the 14 French catheter, it is a spear, and it is a very thick, stiff spear in the left atrium. And so you have to give it respect. Versus the 8.5 French catheter, it's a little bit more like a noodle, and you have a little bit more flexibility and maneuverability with it. You have to respect it, but not like the 14 French. And there's other manufacturers. I think within the next 2 years, we're going to see 2 other manufacturers come out with their versions of 4D ice catheters. And so it'll be exciting to see where we go with this. It is certainly feasible. It requires, I think, a lot of technical expertise and experience, and it takes a team to do that.
Just a practical question for those who are doing ICE guidance for either MitraClip or left atrial appendage occlusion. Are you trying to operate the device and the imaging at the same time, or do you have a second interventionalist helping you, or do you have an imager that's helping you who's scrubbed in? How are you handling that?
I can take a stab first. I would say, so I'm the operator, the only operator, and a fellow helping me, and I love it. I just love being able to manipulate everything myself, and just guiding my own transeptal, knowing which view I want. And but it is true though. So once you get across with the ice catheter and get the second sheath in position, that can tweak. So I do need a second person, be it nurse or a fellow, just to hold the ice catheter still as I'm deploying the device itself. But it is actually very fun to do so. But it also means you're scrubbed longer. So I would be scrubbed for the entire, say, 40 to 60 minute duration, as opposed to when it's a TE guided case, I'm scrubbed for like 10 to 15 minutes. So just be prepared for more back pain.
Yeah, so what we've done is we've done it both ways. The one of the good things about the 4D ice catheter is that once you kind of park it, there's a couple of ways to look at the appendage. You can either come into the left atrium and kind of flex back and look at it en face almost, if you will, or you kind of turn it around and retroflex and kind of look up at the appendage. And then you can do multiplanar reconstruction. So once it's in a stable spot, the rest of the manipulation is actually done on the console by whoever your imager is. And if you have somebody who's experienced with multiplanar reconstruction, would say the Epic device, for example, then it's very facile, it's very quick. You almost have to do very little manipulation with the ICE probe itself for a Watchman case. For a MitraClip case, it's a little bit different. We've had a series of cases now that we've done without transesophageal echo due to some sort of prohibitive esophageal anatomy. And for that, it almost does require 2 experienced operators. One, somebody who's experienced on ICE, somebody who's experienced on the device, and you have to kind of communicate back and forth and manipulate, because there's very little that's actually done on the console. It's all done by maneuvering.
Gagan, with the size of that 14 French and the MitraClip sheath, are you requiring any closure devices across the septum at the way out?
Yeah, good question. So what we've generally done, so Steve, who was on the line, Steve and Carlos have done a series of cases. Bridgemani's done a few cases, and Sammy at MGH just did a couple of cases too. So the global experience of patients who cannot tolerate any imaging at all, transesophageal echo or transthoracic, and it's just done on ICE alone, is probably less than maybe 15 to 20 patients. And usually what we do is we do a transeptal puncture. After that transeptal puncture, we'll use a 8 or 10 millimeter balloon. And so first you get your ice catheter across, then you get the transeptal sheath across. So it's the same hole. Earlier on, there was a few cases where there was 2 different transeptal punctures, but I think now everybody's kind of gravitated towards using the same hole for both the ice and the MitraClip guide catheter. When things come out, the hole is a little bit bigger. Normally our MitraClip 22 French is a slit, so that measures anywhere about 8 millimeters or so. These ones are a little bit bigger. They're about 1.2 millimeters in the case series we have, which we're going to submit for publication here shortly, but it's still a slit. On all of them at 30-day follow-up, there's still been persistent left to right flow. We have not had to close any single one yet.
What's been your experience with 40 TE for tricuspid clipping? I imagine it'd be very useful there.
Yeah, we've, for part of Triluminate and then also some off-label cases, we've had the transesophageal echo in, and then we've had the ice catheter on standby if we needed it. I remember when we did our first series of Triluminate cases, I texted Paul right away, and I told him, I was like, there was one case that we thought was just going to be very, very difficult with transesophageal echo. And that was the one where, the images were beautiful. The device got in there. I could see leaflet insertion. We got a couple of clips on. The patient did fantastic. The case after that, where we thought, imaging was going to be easy and this should be a really quick case, it turned out to be the most difficult imaging case we've ever done with transesophageal echo. And so we had the ice catheter on standby. We got it up there. And again, the NPR function on the 4D ice was very helpful, because it allowed you to get the orthogonal view of the clip and you can see leaflet insertion. And so it certainly as an adjunctive tool, I think it is phenomenal. I think within 5 to 6 years, we're going to see it potentially supplant the need for transesophageal echo as the technology improves.
I think certainly we have learned a lot about imaging of the tricuspid valve from different angles, especially going into the stomach and even doing deep gastric views. But there are just some things you cannot see on the other side, like prosthesis and such. And I think ICEs can be very helpful for that. And so it'll be interesting to see where that goes, especially your case, Gagan, was a horizontal heart, right?
Yep.
Yeah, those horizontal hearts can be really, really challenging.